Hello everyone, my name is Rachel Jones and I am an ST7 in respiratory and intensive care medicine. And I'd like to talk a little bit about intensive care for the medical registrar. I am possibly in a unique situation that I am a dual trainee and have done 3 years as a general medical reg in a respiratory GIM post before taking up an ICM training pathway. So I think I've got a flavour of both and hopefully can answer some questions that you might be thinking about intensive care. The key thing is demystifying it, because they are two specialties that work brilliantly together. And what I'm going to do is take you through a bit of a journey of before the intensive care unit, where medicine and intensive care interact, looking at what intensive care can do, going into sort of the post-intensive care path of a patient's journey. And I think I'll start with who should I refer? And the best thing about medicine is there is no black and white. The worst thing about medicine is there is no black and white. And we work in greys all the time. But I think there's 3 main things you should think about when you're seeing someone who's sick and are thinking of making a referral. And these 3 pieces of information are the key bits to refer. Firstly, what's wrong? Have you got a diagnosis? And that's not necessarily a bad thing if you haven't, but it gives you some more ideas of what's going to happen and where you're heading. What can be done? What needs to be fixed at this point? What is actually going to help this patient get better? And is this overall process reversible? Is this something that time or a medication is going to make a different outcome? Or is this part of a progressive illness that we have no cure for? And intensive care, we work with this glorious term of organ support. And I wish I had these tablets because they look brilliant. And that's where this, is it reversible? Is it something we can support this with, is important, because we can't support all organs. And finding out a little bit about, hopefully this talk will show what sort of things we can do. And I put this slide in, which gives you an idea that we all are a little bit different. And that's what the same in all specialties and certainly in medicine. And that's okay, but it gives you a bit of a flavour of why the things might be different. Intensive care is a consultant-driven specialty. Most admissions come from a consultant accepting them, which is a bit different than medicine, where you have all comers. This is a little piece from a Welsh study looking at consultants and what they accepted to the intensive care unit, what they didn't accept. And looked mainly at what they accepted in this bit and what they were expected to expect based on the amount of time they were on call. And the O to E number gives you an idea that is a bit different from person to person. And that's what we would expect in terms. So why is that important when you're referring someone? I think it's about not being disheartened and getting the information together and realising that there is difference between what some people will accept and some people won't accept. That doesn't mean you just keep ringing back to get the right answer, because ultimately there's a lot of crossover and a lot of things that are exact, but it's giving a flavour that there's a human element to this. So my next part and question is about, why are you obsessed with shopping? Why do you keep asking me about the shopping element? And basically it's to tell you that medicine is ahead of the game. You've got the frailty. Frailty is the new shopping. And frailty scoring is really just beginning to take off in intensive care. And people probably aren't as familiar with it as medics are in frailty scoring. So shopping as a sort of ADL, activities of daily living, history taking, gives you an idea of someone's pre-morbid function, how fit, and sort of judging from that their physiological reserves. It's not surprising, though, that the frailer you are, the increased rate of hospital mortality in intensive care. So this is a 2017 systematic review that shows that if you are frailer, you have a higher hospital mortality. This is the most recent European study of 2020, which uses clinical frailty score and says the same sort of thing, that those who have a clinical frailty score above 5 have a higher mortality, or in this thing, the overall survival probability is lower. So what can we actually do in intensive care? So monitoring is probably the first thing I'd like to talk about. So we can monitor a patient both through toys and our monitoring devices. So this is a monitoring screen, and as you can see on it, you've got a continuous ECG, an arterial blood gas, that's the red one, so that gives you a beat-to-beat blood pressure reading, a pulmonary arterial pressure, so you can float a catheter and wedge it into the pulmonary capillary wedge pressure. You can get SATs readings, you can have a respiratory rate and a non-invasive blood pressure. You can also do intracranial pressure monitoring. There are so many things you can monitor. What comes with that is quite invasive, and for pulmonary artery pressure, a Swan-Ganz catheter or a right heart catheter is an invasive procedure, and it carries risk. Everything carries risk. This is a really nice infographic that's in Southmead Hospital in Bristol, and there's used to sort of convey what's going on around the bed space. And it's really helpful for patients and family so that they can get a flavour of what's happening. And particularly the family who are coming in to see their relatives, it can be overwhelming how much stuff is in that space. But it's quite good for us to also think about what's going on. So on that monitoring side, it comes with lots of physical machines. So what organs can we actually support? So the common ones that we talk about is the breathing, and that is the top right part of the screen. This is a Draeger ventilator. People have become very good at ventilators in this recent era. My mother knows a lot about it through the BBC, and it's a hot topic, but they essentially can help support people's breathing by blowing air in and out. They are got different modes on them, but the idea is that they will take over or augment people's breathing. I've put up a pump in the middle, a section of syringe infusion pumps, and they are representative of the cardiovascular support that we can give in intensive care. So we can use vasopressors, drugs that squeeze the blood vessels and therefore augment people's blood pressure, and inotropes, drugs that help the contractility of the heart, which can augment your heart function. And top right, I've popped in a Prisoners filter machine. So these are a renal filtration device. Now there's loads of different types and there's loads of different modes. So there's some general principles that I'll mention. They are along the same lines as a dialysis machine in renal, but are often slower because we want more cardiovascular stability. So that's important when you're thinking about referring a patient. So if it's someone who's already well known and may have missed a dialysis slot and is presented with a high potassium, depending, sometimes the dialysis is actually quicker at achieving the correction than our filtration machines. Now there's different modes and I won't go into it because it all gets a bit technical, but it's worth thinking that the filters in intensive care are slower and stabler. Some of you may get asked or get phone calls saying we're stepping someone down, we're stepping someone here. What does the stepping mean and what's going on with that? So stepping comes about from our levels of intensive care, and this is outlined in the GPICS document, a long document all about what makes a ward in intensive care versus what would make it a respiratory ward. And it sets out some of the standards that should be obtained. And it's how they describe the sort of complexity and level of care needed for the different patients in intensive care. And as someone gets sicker or needs more support, they go up the levels. And then as they get better and need less support, they step down those levels. Level 0 is what a ward-based care in an acute hospital is. So when you're stepping someone down, you're stepping them down to your ward. And that doesn't mean that they are stopping their treatment or withdrawing treatment. It's just a turn of phrase. So I'm just going to talk a little bit about handover, because as I hint there, intensive care handover can often happen to the ward team, but there are a period of times where patients may be handed over as stepping down out of intensive care and may come on the out of hours team. There's a recognition that handover is better if you verbally hand over as well as a written handover. So there's often a phone call to the team, and sometimes that's an on-call team, especially between the hours of 5 p.m. and 10 p.m. Tend to not discharge so many patients later on because of increased correlation with mortality and adverse outcomes and readmission. But sometimes, especially in medicine, that may not be the admitting the team that's looking after this patient long term. So you may get handover about a patient and there may not be any actions. But I'd implore you to review these patients, because they have been the sickest patients in the hospital. And I know it's stressful and there will be times when you can't do it, but creating an environment where that's encouraged, I think, is really important. You may, in your specialty, be asked to review a patient who you've sent to intensive care or has come up with a new physicianly problem in intensive care. And I'd again implore you to visit the intensive care unit. It'd be brilliant to get a closer bond and a closer working relationship with medicine. You are the most the best at managing physicianly problems, and if you're called, it can really, really help patient care. So I'd implore you to go and visit. Readmissions. So there is no hard and fast rule about readmissions. Some patients will come back again many times through their hospital stay. Some patients, it may not be appropriate for their care to be re-escalated to intensive care. Now, sometimes that's on our treatment escalation plans, on handover documents. It's often in the discharge summary from intensive care, and that's another reason to have a read of that physical form. That can be helpful if you're seeing a patient for the first time in A&E to have a look back at their intensive care discharge. However, it's really worth noting that sometimes patients' conditions change quite markedly for the better or for the worse, and things are not quite the same again. So there's no hard and fast rule. Finally, I'd just like to talk a little bit about tracheostomy. So sometimes you will have a patient step down to you with a tracheostomy. It's part of a way of weaning patients from a ventilator, part of the weaning function. In intensive care, they often would get a tracheostomy, or that is changing slightly. There's probably less happening now than there were 10, 15 years ago, but it's still a relatively common occurrence. This is a Portex tracheostomy. They are lots of different types. Tracheostomy tube. Tracheostomy is the hole in the neck, and the hole in the neck is used because it helps liberate sedation, because it's less stimulating than an oral endotracheal tube. It also helps minimise the dead space, which helps reduce the work of breathing and helps people to wean and strengthen their respiratory function. But lots of different types of tubes here, and that's not the most important part. The most important part is knowing a little bit about what's going on with the patient. So as you can see, there is a tracheostomy and a laryngectomy, and they are two different things. And this is from the National Patient Safety tracheostomy audit that has said that all patients should have these signs by their bed space. These signs help tell you what you should do in an emergency, and it's really important if you're getting any patients from intensive care that you look to find these signs and make sure and advocate that they should be by the bed. So the tracheostomy green forms show that they could potentially have oxygen from the mouth and the neck. The laryngectomy patients, there is no connection from the mouth and they are neck breathers, and therefore all augmentation must be through the neck. On the reverse of those forms is an algorithm to help you in an emergency. And that's the important part. Have a look at it, because although it says call for expert help, it may give you some ideas of what you can do until help arrives. So we've had a little whistle-stop tour through intensive care, looking at what happens before intensive care, some of the information that you should gather on these patients, talking about our obsession with shopping and the new frailty and how that plays into intensive care. Looking at exactly what we can support in intensive care and those three main organ support that we offer: ventilation, vasopressor, inotropy, and renal filtration. And then we talked about the post-ICU with handover and tracheostomy. I am going to do a little shout out in terms of dual training with intensive care. As you can see, I am a big fan. I'm happy to talk to anyone about it. I'll put my email address and my Twitter handle down. I think it works really, really well. The specialties currently, acute medicine, renal and respiratory, all have accesses into dual training. I hope this has inspired you, and look forward to some questions later. Thank you.